Okay, good evening, everyone. I was just giving it a few minutes for people to filter in. It's 6:30. I'm gonna get started right on time. People can join us late if they arrive a little bit after the fact. I want to say good evening and welcome everyone. Thank you for joining today's webinar, which we're calling The Future of Board Recertification, brought to you by the National Board of Physicians and Surgeons, or NBPAS as we call it for short. And I want to thank you for taking the time to learn more about the progress that NBPAS has made to provide physicians with a choice in board recertification pathways. My name is Karen Shatton, and I serve as the Associate Director of the National Board of Physicians and Surgeons, and it's really my pleasure to bring you this information today. I just want to go over a couple of quick points of business before we get started. Overall, I anticipate the presentation will take about 20 minutes to share. This may be your first time hearing about NBPAS. If so, we welcome you and we thank you very much for your interest. This is a one-way webinar format in that we will not be hosting a live chat or question and answer session. So we absolutely want to hear any questions or comments you may have, and you can please feel free to send them to us at our email address, which is info@nbpas.org, nbpas.org. I'll share that again at the end of the presentation. That sums up business, and with that, I'll get started. So the National Board of Physicians and Surgeons was founded to support lifelong learning, clinical excellence in medical specialties and subspecialties, but also in a manner that is professional and with the care of patients central to physician learning. And in achieving these goals, it's also always been important to NBPAS to fulfill its purpose through a pathway that is more efficient than others and much less burdensome on its physicians. And what I'm going to do tonight to help you best understand our purpose and mission, I think it's also useful to understand a little bit about the evolution of physician board certification over time. So knowing the background can really help contextualize our organizational history and how we came to be, where NBPAS fits in at present in the current landscape, and how we're really providing leadership on this issue with respect to the future. So the way it's laid out, I'm going to start with a brief historical look at board certification, talk a little bit about what changed, some of the unintended impacts of those changes. I'm also then going to provide you sort of a high-level understanding of NBPAS as an organization before concluding with a deeper dive into the specifics, which will include our clinical requirements and the value, frankly, of NBPAS to physicians, patients, hospitals, and the broader healthcare system. Finally, conclude with the methodology to become certified through NBPAS and or to bring it to your hospital or employer. So here we go. Historically, physician board certification was understood as a mark of excellence and distinction, which is no surprise to any physician who has achieved it. If you look to the left, you could read this quote that originated in the minutes of a 1939 meeting of the American Board of Psychiatry and Neurology. It sums it up really well. Purpose to distinguish the fully qualified specialist from the would-be specialist of inferior training and inadequate experience. Certainly no one wants that. In the most practical terms, it means that a physician has achieved the highest level of possible education and training through participation in a residency and fellowship and passing the associated board exam. And again, if you're a physician, this information is not new to you and you are well familiar with the degree of rigor associated with your residency training and that culminated with the passage of your initial board exam and the significant distinction of becoming board certified. But around the year 2000, the dominant board certifying body in the US initiated a major change that affected all of medicine. Before the 2000s, board certification was defined and well understood, again, as the completion of the residency program and demonstrating competency and mastery of your specialty through passage of the board exam, which really can be thought of as the final exam of residency training. Board certification was always a lifelong credential, but it's really important to point out that a lifelong board certification credential did not ever equate to professional complacency or any sort of cessation of training. Physicians have always been required to engage in continuous and lifelong medical education. And quite frankly, I think studying and learning is a deeply inscribed value and part of a physician's learning and training. Physicians as a group are known to be natural, passionate, and lifelong learners. What I really want to emphasize and what's important on this slide before I move on is the last bullet, so I'll just draw your attention to it. It's important to understand that the entire administrative landscape of privileging, credentialing, and reimbursement was based essentially on the pre-2000s understanding and meaning of physician board certification. So keep this in mind. After the 2000s, what happened? So the dominant board certifying body in the United States, which is a nonprofit organization, made a change that effectively changed the meaning and understanding of board certified. So this particular board developed their own proprietary brand of continuing medical education, which came to be known as MOC or OCC. And fully board certified physicians were suddenly mandated to participate in this proprietary continuing education product, or else essentially be stripped of the board certification credential. Now, if you're a physician, you probably know this story is actually a little more complicated than that. Board certification became what's known as time limited for some, and MOC or OCC was a requirement, whereas it was also kept time unlimited for others, where MOC or OCC was not required. So this practice of exempting a large swath of US physicians from participating from MOC or OCC became known as grandfathering. And at the time that the policy was initiated, it's estimated that about 40% of US physicians were grandfathered, while the other 60% were then required to participate in MOC or OCC. And important to recognize that grandfathering still continues today. I'm not going to get into the obvious controversy that resulted from this change, but really instead focus on the real and practical impacts of those changes and what happened next. But for all practical purposes, the time-limited physicians would lose their board certification title without that mandatory participation, and they faced potential loss of privileges, employment, reimbursement, because all credentialing requirements were based on the pre-MOC definition of board certification. In theory, the MOC product was called voluntary. In practice, it became a de facto requirement for anyone with a time-limited board certification. To underscore this point, and as an example, this slide shows a study done in the radiology community. The American College of Radiology, or ACR, studied this based on problems reported to them by their physicians, and this is from that study. The change in terminology of certification to include MOC has created ambiguities in regulations for many organizations, because innumerable legacy bylaws and regulations that refer to certification may now unintentionally refer to initial certification plus MOC. And going further, they note these consequences to include possible termination, losing credentials with insurance carriers, and also as a sort of outlier being denied as an expert witness. And we get these calls regularly at NBPAS. These unintended consequences are real, and we hear from physicians on these issues every day. So the National Board of Physicians and Surgeons was founded in response to these changes and to continue to provide physicians with a choice to maintain board certification using specialty-specific CME rather than MOC. I do want to emphasize that NBPAS requires all of its physicians to be initially board certified through ABMS or AOA specialty board. So essentially all NBPAS physicians are board certified physicians. We very much believe in the evidence-driven importance and the value of the initial board certification, and we do require it without exception. I think the differentiator here is that physicians maintain ownership of their learning agenda and find activities and study activities that truly meet their unique clinical needs. So in essence, the only difference between NBPAS and the other boards is maintenance or continuing medical education. If you look at NBPAS first, we maintain with ACCME accredited CME. The other boards use their proprietary MOC or OCC product, repeated exams, and also in some cases also CME. I think what's even more important to see is where we align and how similar it is, because what truly trains a physician to be board certified and a specialist is the education and training, which is the residency. So all three boards, inclusive on this, that we're talking about, we all require the same residency and or fellowship, the same initial board certification exam, and we recertify in these specialties and subspecialties only. There's a lot of evidence that supports the value of the initial board certification exam plus CME, which is the basis for all of the NBPAS requirements. So I want to talk a little bit about ACCME and their CME offerings. They have always been the primary currency of continuing medical education in the United States, and their CME is designed to ensure that whoever's providing those CME courses offer learning that is evidence-based, cutting edge in terms of relevance and timeliness, and also outcomes focused. CME activities also generally require activities that test or measure changes in competence and or performance, with also additional focus on patient outcomes. So it's a highly measured learning opportunity. I'd like to point out that ACCME has been the dominant provider of CME before 2000, before anything changed with board certification. They remain the dominant provider of physician learning after 2000, and as an example, provided over 170,000 CME opportunities in 2020, with close to 3 million learner interactions that specifically addressed COVID-19. This really gives you an idea of the adeptness of ACCME to quickly pivot, even in response to something as rapidly emerging as a global pandemic. And we do hear pretty regularly from our NBPAS diplomates that some of the MOC and OCC continuing learning modules really had no questions related to COVID-19, and that those tests typically run about 3 to 5 years behind current clinical thinking and practice, just based on how they're developed. So ACCME accredited CME stays very current. The ACCME also recently took very deliberate and thoughtful action to remove conflicts of interest and third-party profiting in continuing medical education. Their accreditation standards are quite rigorous, and we learned in recent conversations with their CEO, Dr. Graham McMahon, who shared with us that they annually remove up to 5% of CME providers that may violate their standards, whether it be for content or the integrity standards, and they offer their highest level of endorsement only for the top 20% of CME providers. So we understand that some physicians may simply prefer other maintenance pathways, and that's okay. When a hospital goes to add NBPAS to its credentialing standards, it's not a choice of Board A versus Board B. This is a situation of Board A and Board B. NBPAS is additive to credentialing standards. What it really boils down to is that physicians now have a choice in how they want to recertify. And it's okay for intelligent people to agree to disagree. NBPAS very much agrees with the quote at the bottom supplied by Gandhi: honest disagreement is often a good sign of progress, and NBPAS certainly we think is a good sign of progress. You know, why is NBPAS important right now? And why is it especially important right now? And I think at this moment in healthcare, one of the answers to those questions is burnout, physician burnout, which has been identified as a public healthcare crisis in all serious terms. It's estimated that 20 to 25% of physicians will be leaving practice within 5 years. These are not necessarily retirement age physicians. These are physicians that are burnt out and done with medicine. And reducing physician burnout really requires a diversified approach with real solutions. And burnout is much talked about, yet things like yoga and meditation and resiliency training are probably not on the leading edge of the solution. Many physicians specifically cite their unwillingness to participate in onerous requirements as a contributor to early retirement or decision to change careers. So NBPAS is an option on the leading edge to help reduce physician burnout by offering a recertification pathway that is designed specifically to reduce the burdens associated with lifelong learning without compromising on clinical quality. That's a good segue to now take a deeper dive onto NBPAS more specifically. So what started out as a grassroots effort has become mainstream, nationally accepted, and rapidly growing board recertification body with close to 10,000 physician diplomates and over 156 hospitals, health systems, and others accepting. So we always list our official numbers, hospital numbers especially, with a plus sign as a caveat, because the 156 is the number of confirmed facilities, but we often find that there are many others out there that we may be unaware of. So we only list those that we have officially confirmed through due diligence. Founded in 2015 by Dr. Paul Tierstein, Medical Director of Scripps Previs Cardiovascular Institute, also the Chief of Cardiology and Director of Interventional Cardiology at Scripps Clinic in California. And although I know you won't necessarily take the time to read all these names, you might be interested and recognize some of your friends or colleagues. This is our board of directors, which are widely known in their respective specialties as thought leaders in clinical and academic medicine. It's important to point out that all 20 of our NBPAS board members volunteer their time. They are fully unpaid, and they come from some of the most recognized institutions in medicine, some of which are represented here. And probably the biggest and most commonly asked question we get asked about is NBPAS accepted? And the answer is yes. So NBPAS has worked very diligently to establish that it is fully accepted by all the major national accrediting bodies for both hospitals and health plans. On the health plan side, there are a lot of acronyms in this world. On the health plan side, it includes organizations which we call NCQA and URAC. On the hospital side, it includes the Joint Commission, which many of you know as JCO, but they renamed themselves the Joint Commission, and another hospital accreditor that is growing rapidly called DNV. And this slide is simply a continuation of the previous, and it shows the official confirmation letters from the nationally accepting accrediting bodies confirming NBPAS as accepted. So we have Joint Commission, DNV, NCQA, and URAC, and we can certainly at any time provide these to your organization upon request. I'm going to do a pivot again and dig a little further into the specifics of NBPAS requirements highlighted here. As I mentioned before, NBPAS absolutely requires initial board certification through an ABMS or AOA specialty board. So physicians who are recertified through NBPAS are all board certified physicians to start. Going forward in the maintenance phase, we require 50 hours of practice-specific ACCME accredited CME, which is category 1. Every 24 months, that number jumps to 100 hours if a physician's board certification has lapsed. NBPAS does also require privileges, active privileges for some surgical specialties, either outpatient or hospital, and some of the other basics include an active or unrestricted medical license, and our cost comes in at an average of $94.50 a year. I just next want to give you a quick look at the NBPAS website, which our web team recently rebuilt for ease and convenience. It's really designed to be as straightforward to physicians as possible to either apply or recertify, and similarly easy for credentialing staff who need to log in and verify a physician's board certification status for employment. Hopefully it's something, hopefully users will agree that it's working well. As I mentioned earlier, NBPAS is growing rapidly, particularly on the heels of our recognition by all major national accrediting bodies. These are just a few of our accepting hospitals. We're always excited to hear about new additions to our list, and in recent days we've added 2 major telemedicine companies with coverage in all 50 states, and we do expect that number to grow in the near term. We also often get asked, where do NBPAS physicians work? And the answer is everywhere. They can be found at work and in practice all over the United States: hospitals, health systems, academic centers, physician groups, private practice, and many other private and public physician employers, which you see listed here. This is by no means exhaustive, but should give you a good sense of the breadth and depth of our NBPAS diplomates. The second most common question we receive is probably, does insurance or payers accept NBPAS? Couple things in the answer. Insurance requirements can differ state to state, as there are close to 6,000 registered health payers in the United States. Insurance is regulated at the state level, but as I mentioned earlier, NBPAS meets all accreditation requirements for payers, and we're finding that most already accept us. There may be some cases where they are not yet aware that NBPAS meets their requirements, and we continue to educate those payers by engaging in discussions on a case-by-case basis and with some of the corporations at their very highest levels of leadership. So we simply suggest that you ask and confirm, and if you find misunderstandings, we're always here to we're happy to support and assist in those discussions as needed. But overall, we're very happy to report widespread insurance acceptance. As an interesting side note, and just something to be aware of, national accrediting bodies actually do not require board certification. They require something called primary source verification, or in the world of acronyms, PSV for short. Primary source verification requires credentialers to verify the highest level of a physician's education and training from the primary source. The highest level of a physician's training is often board certification, and so it's the simplest, easiest, and most direct route to certify a physician's education and training by verifying their board certification status. And as I mentioned earlier, we require all NBPAS physicians to be board certified. And so as a criteria for our NBPAS recertification, we always perform primary source verification on all our physician diplomates. So what are the benefits for physicians to recertify with NBPAS? There are many. For starters, we provide a pathway for rigorous, continuous, specialty-specific lifelong learning, but we do it in a way that's more streamlined and in both substance and process to reduce burnout and administrative burden. Time saved equals not just money, but really the most important thing, which is increased focus on patient care, and it's economical as well. Also, we prohibit grandfathering and do not allow unlimited board recertification. So our requirements are the same for all physicians. In terms of benefits for hospitals' employers, I think there's a number of direct and indirect savings that are among the biggest benefits, who often reimburse and pick up the cost of physician continuing certification. Because physicians now seek out NBPAS and prefer it as a pathway, having NBPAS added to your bylaws supports physician recruitment and retention. It does reduce direct hospital costs by 73% in terms of those recertification fees. There are a lot of indirect cost savings in terms of lost time, productivity, and physician turnover. An interesting study just came out that $260 million per year is lost to physician burnout and turnover. There's incredible cost associated with loss of physicians and recruitment. So that's paid for by employers, it's paid for by health plans, and ultimately by taxpayers. Also, there's a lot of interest and attention given these days to diversity, equity, and inclusion goals. And again, we strictly prohibit time unlimited grandfathering, and we require equal standards for all physicians. And we think this can help really support a culture at your institution that is physician friendly and supportive. We don't ever want to add to anyone's already busy workday. So luckily, adding NBPAS is really very straightforward. So typically, a physician will share background information with colleagues or medical executive staff, which reviews and decides to vote and accept NBPAS and add us to their bylaws. Once we're in your bylaws, you're good to go. And physicians who have done this and embarked on this process at their hospitals and health systems report. It's really quite straightforward and easy to do. So just as a quick summary, the future of board recertification is recertification that is clinically rigorous and evidence-based, but also value-driven and less burdensome. NBPAS is a way to do that in a way that's nationally accepted. And we're very appreciative of your time and attention to learn a little bit more about us today. So that concludes my presentation, and I want to thank you again for your time and attention. Once again, you can please feel free to reach out to us by submitting questions or comments to our general info email box, which is info@nbpas.org, info@nbpas.org. If you're interested in certifying with us, please also visit our website, nbpas.org. Click on apply, and we're happy to answer any questions. We're always here to work with you, and we thank you again. Have a great night.